All right. This is Jaylee Burney. She did her undergraduate and medical school at the University of Kansas, and she's going to talk to us today about her research project.
Okay, hi everybody. I'm Jaylee, and today I'll be speaking on the semisitting position for the retrosigmoid approach to the vestibular schwannoma and our institutional change in practice. So the semisitting position is employed for a variety of pathologies. At our institution and historically, the position is primarily used for vestibular schwannomas and other cerebellopontine angle tumors such as meningiomas. The most prominent reason for hesitancy is the dreaded venous air embolism in this position. The main reason for the stigmatization of the position has been the venous air embolism for years and years and years. Although there are other disadvantages, such as risk of arterial air embolisms in PFOs, pneumocephalus, and the time-consuming setup. The concern for the dreaded complication of the venous air embolism was first mentioned in a paper by Hitzelberger and House in 1980, and it has been stigmatized ever since. So, is the position as dangerous as the stigmatization makes it seem? Neurosurgery pioneer and legend Joe Ransroff stated that, having had personal experience in the past 30 years with the use of the sitting position in the treatment of acoustic nerve tumors, and experience that obviously predates the operating microscope and even our current sophistication in the management of air embolism, I respectfully submit that Hitzelberger and House have overstated the case. Yet, still after this, the position is not widely used. Many studies on the safety of this position have been done. Here's a significant study in the Journal of Neurosurgery published in 2017. In this multi-center retrospective study, 425 patients underwent surgery in the semi-sitting position for various pathologies were analyzed. 21% of patients had a detected venous air embolism. However, not a single operation needed to be stopped due to the proper protocol and staff, concluding that even in the presence of an intraoperative VAE, proper interventions ensure the safety of the patient, allowing the benefit from the position. What are the advantages? Well, for one, there's better operative visualization. The CSF and blood run out of the field due to gravity as the cerebellum relaxes, aiding not only in the visualization, but also allowing the surgeon to operate without suction constantly in one hand. Another major benefit of the position is the shorter operative times. Vestibular schwannomas have quite the reputation in neurosurgery for being prolonged surgeries with painstaking precision to avoid not only damage to the facial nerve, but also to the brainstem itself. Better visualization and a less need for constant suction frees the surgeon to work more quickly in a safe manner. Given these advantages, two of our senior school-based surgeons, Dr. Camerata and Dr. Shamoun at KU, traveled to Germany in 2018 to learn more about the position. After their educational experiences in Germany, Dr. Shamoun and Dr. Camerata converted all of their vestibular schwannomas to semi-sitting position in the retrosigmoid approach. And all of this was inspired by Dr. Sammy in Hanover, Germany. The proper protocol and setup of this position is the key for the success and benefits of the surgery. At KU Med, we adopt the Tvungen protocol. The protocol is intraoperative TE, flex extensor spine films, a central line, continuous neuromonitoring, and access to the neck for jugular compression. And here's an example of what the setup should look like with the legs within the level of the heart. And then here's some pictures of it actually being implemented at KU. So to further analyze this position and its benefits, we performed an analysis of operative cases that were done in the semi-sitting versus supine position for vestibular schwannomas from 2014 to 2023. We looked at only the vestibular schwannoma pathology. Our whole objective was to provide the institutional evidence for the benefits of the semi-sitting position as compared to the supine positions, using the surgeons as their own controls. We looked at operative time, blood loss, clinically significant VAEs and postoperative complications, gross total resection rate, length of ICU stay and hospital stay, and the 30-day hospital readmission rate. We had a total of 62 participants, 49 of those in the semi-sitting position and 13 in the supine. Here you can see the postoperative complications. Of note, we had 9 CSF leaks in the semi-sitting retrosig and 2 in the supine, and we had no clinically significant venous air embolisms at all. The operative time for the semi-sitting position was significantly shorter than the supine position. The average operating time for the semi-sitting was 359 minutes, and for the supine position was 467. Ultimately, the average setup time was increased in the semi-sitting, but the total time under anesthesia was still less in the semi-sitting position versus the supine position. Overall, the semi-sitting also had a lower change in hemoglobin before and after surgery. The average change in hemoglobin for the semi-sitting position was 0.97 versus the supine, which is a change of 1.41. The overall time spent in the hospital for semi-sitting patients was shorter. ICU stay for semi-sitting patients was 2.34 days, excuse me, and the supine was 3.69 days. The overall average hospital stay was 4.91 days for semi-sitting versus 5.84 days for the supine position patients. The 30-day readmission rate was similar between the two, as well as gross total resection. In conclusion, there is evidence to suggest the safety of the semi-sitting position. Our institutional review showed that the semi-sitting approach for vestibular schwannomas results in shorter operative time, less time under anesthesia, and lower blood loss. The data indicates that gross total resection rate and length of hospital stay are improved as well, but need to be further studied with more data points. So this is a very unique study in which the surgeons serve as their own controls. We looked at their supine from 2014 to 2018 versus the semi-sitting from 2018 to 2023. So with proper protocol and staff, semi-sitting retrosigmoid surgery for vestibular schwannomas is safe, effective, and produces comparable results. Thank you for letting me speak, and I'll take any questions.
You mentioned that there were no clinically significant venous air embolisms. Does that mean there were no venous air embolisms, or there were venous air embolisms that were managed intraoperatively without problem?
Yeah, I think there was two, but we didn't have to stop surgery. Anesthesia handled it. There was no so we didn't think that. Yeah, so they were not clinically significant, but I think there were two overall.
Did you put right heart catheters in everybody?
I am not 100% sure.
How did you monitor the embolus? How did you identify embolus?
We had intraoperative TEs and essential line, so anesthesia was moderated the whole time.
So the argument is that you said several points. One is you use the same surgeon to compare historical comparison. The vertical comparison run into one of the bias that 2014, 2018, 18 and beyond, right? So that conceivably could be the earlier part of a surgeon's career,
right? Versus
later on. And a number between 14 to 18 was what, 19 cases?
16, yeah.
16. So relatively speaking, that's quite a low number. Over 4 years, going on 16 cases. So the surgical time naturally go long with a large tumor. So that really run into the trouble to explain. And as you're getting more experience, a lot of setup, a lot of surgeries are different. The semi-sitting position surgery has its own advantage. Naturally, blood runs out, CSF runs out, gravity take care of the cerebellum. That has been sort of a known benefit in terms of approaching the infratentorial lesion as well as in pineal region. The issue being well adopted is that the surgeon's position is so uncomfortable besides everything else. Obviously, venous sinus, cerebral venous embolism, and all those are the potential issues. But when it comes down to the surgeon's position, arm position, with the long surgery, that has always been a struggle. So depending on how well you're going to handle this, I know some have been doing that, but again, that has always been.
So Rock, are you going to start your trial now? The state perspective.
Oh yeah, you're gonna fund me.
Yeah.
You're gonna fund me.
Can you show
So
us
the idea here, I don't know if you got residents that understand what I tried to say. So semi-operating position, this is what I'm sitting right now. Literally, I'm sitting like this, the operator. Scope goes up straight, and naturally scopes no longer, the observer scope and the object scope is no longer bending certain degrees. It rather goes straight. So that's the longest axis of the scope. And I think the Pantera company has the shortest scope versus everyone else. The other word is that this even that's long. So I'm not a tall guy. I mean, I hear someone, I mean, a lot of people 6'5", I'm sure. That's not a problem. Arm goes out like that. Let's do this. You're gonna hold this arm for the next, how many hours?
4.
Well, let's do 5 minutes. Have you guys hold that 5 minutes?
Well, you're not holding your arms in the air, you're resting.
I understand that. I understand. I understand that. That's why I tried 5 minutes. But then let's do the second part. And the second part, arm rests on this, elbow rests on this. Try this part. This joint. I ask everyone to do one thing. Have anyone seen the pianist play piano like this? And this is a simple idea. The idea is that all the microsurgeons, the tactile control up here. Rare use wrist, but the wrist had to be drawn. So that's the argument, technical challenge. It's not your part. I'm just saying the whole concept of never being very well adopted. I mean, a few people still doing that. There's no question about that. But it depends on how you think. But if you're doing this all the time, everything can go such a way. You're in F1 driver's position. That's different, but overall, it is very hard to adopt this position. And the challenge is coming down to where is the facial nerve? Facial nerves are always 90% of the time, I can't say always, 90% of the time in front of a tumor, which is deepest part of the tumor, which after 2.5 hours or 3 hours, 4 hours, 5 hours later, that's the time you encounter the facial nerve, you separate facial nerve. That's the time you get into fatigue challenge. And that's the time you get in trouble. So that's my argument.
Can you just go back to your picture of the semi-sitting position? I just want to take a look at it again. I've only done a few of them. Like, I think the last one I did was in, we were doing an acoustic, and it was in Ireland. The Irish consultant would do a lot of acoustics, and he did his acoustics in the sitting position. I think it was a semi-sitting. And at noon, I remember we still had like a lot of tumor, and it was noon. He goes, "Okay, lunch break." And he throws the towel on the wound, and everyone leaves the OR. I was like, "What the hell's going on?" The guy was like, "It's time for you to go to lunch." And so we all went to lunch. Came back and finished the operation for the next 3 hours. Yeah.
What do you have for lunch? They even have there were actually cases that cigarette break, the smoke break.
Yeah.
Shepherd's spot.
But you can see what I described here. That's F1 driver's position. Okay, this is reclining back all the way up and facing up with scope. This long is actually, so the arm requires much longer extension. That is the challenge. Well, I do think that it's one of the things you had to consider though. This guy's a big guy with short neck. When you're in the rotation of a halfway rotation, and the head turn flex until that position does include the potential occlusion of the venous outflow. In that position, you do have some chance in terms of the supine rotation position.
Albert, when he was a resident WashU, got mocked because he was tired trying to do this.
Mhm.
So he started a regimen of doing 200 push-ups a day.
And you got more shakiness. One of the big things about the big muscle bulk, also another part is that muscle bulk, big muscle, particularly forearm muscle bulk, increase the shakiness as the muscle bulk reduce microcontrol. That's a typical.
That's why I don't exercise.
Really muscle.
Thank you very much.
Rock, I agree with you.
worried about the muscle.
You end up having to move your elbows opposite. I've tried to do a lot of calisthenics with my head lateral, always end up like this torture.